Okay, it's now my pleasure to bring forward our first speaker. Dr. James Leduc is a professor of medicine and director of the Galveston National Laboratory at the University of Texas Medical Branch. And he's going to talk to us today about characteristics of the Ebola virus in the U.S. environment. What do we know? And are there assumptions being made based on the science? Thank you for being with us today.
Well, first, let me thank the organizers for inviting me. Let me figure out how to drive everything. All right, so first, let me say that disclaimers. Number one, this is not a comprehensive overview. It's just some observations on some of the key questions. I suspect over the day you're going to hear a lot of duplication because there's only so many examples, and we're all going to be talking about it, so I apologize for that in advance. Secondly, what I'm going to talk about is really heavily influenced on our experience in Texas, since we've had a case there and had worked through a number of the key issues that I think we'll be discussing today. So let me start with just a quick overview. I checked numbers at WHO on Friday, and at that time we had nearly 14,000 cases and a mortality rate of about 70%. So this outbreak in Africa is clearly out of control and is going in a very wrong direction. I think this is important to realize. Significantly, the number of healthcare workers is absolutely astonishing. The healthcare infrastructure has been decimated, and as a result, the international community's responsibility now is to provide the resources there. This feeds back then into our national strategy on how we manage returning volunteers. And I think this is an important key to keep in mind. If you volunteer for a month overseas and then have to add 3 weeks on in quarantine, a lot of people are going to be thinking twice about volunteering, and I think this is a real issue. All right, so what's the risk of introduction? We're all aware of where the outbreak occurs. This is a recent publication just on where flights from Africa go. And they go a whole lot of places, including significantly to Asia, as well as Europe, South Africa, and of course the United States. So there's lots of opportunity for dissemination as we go forward in this. What are we really worrying about? Well, there's maybe 3 groups of individuals that we might consider. The local nationals, Mr. Duncan, I think, is a good example of that category. People that have been infected and just end up on our shores, completely asymptomatic, but subsequently become infected. International travelers, there's a lot of business people go around the world. I'm not aware of this example yet, but I do know it during SARS. We saw that on more than one occasion. So, and then finally, the returning volunteers and healthcare workers, and these are the folks that are really in the news today and an important part, not only for the response, but also for our national discussion as we go forward. So what have we seen in the United States? Well, we've seen Mr. Duncan, who arrived, was hospitalized at a hospital that was clearly unprepared. I submit to you that the experience in Dallas is exactly what would have happened at 99% of the other hospitals around the country, that we simply were not ready. Hospitals in general are not ready to manage this kind of a case. As a result, a couple of nurses became infected. Fortunately, they've now survived, and they were treated well at Emory and NIH, areas that had established the capability to treat these patients. We've seen 5 American workers that have returned from Africa back for treatment in the United States to both Emory and Nebraska. Fortunately, these have all survived and have been well. The point here, and I'll make it later on as well, is that if the hospitals are aware of Ebola cases coming, they do a very good job about it. I think now, most hospitals having seen the experience in Dallas, I'm virtually certain that they're a lot better prepared now than they were a month or 2 ago. And our last example is a healthcare worker who self-identified, followed the rules as we've articulated them, and as soon as he became clinically ill, was admitted to a hospital in Bellevue. So what have we learned? Well, the risk of exposure among household and family contacts doesn't appear to be as great as perhaps we had feared. To the best of my knowledge, we've found no secondary cases from either the nurses or Mr. Duncan's family. And recall that Mr. Duncan was quite ill at home, so there appears to be a standard for transmission that's fairly significant. We've gone in and decontaminated 2 residents that I'm aware of, 3 of them, but I don't know the details on the 3rd nurse, but the 2 that I do know about, we really did a cleanup. In the case of Mr. Duncan's house, they even took the toilet. So you heard there was 144 55-gallon drums of waste taken from that. We really don't know how to manage this quite well. Excuse me. Similarly, the medical waste from the hospitals, we had nearly 100 55-gallon drums of medical waste associated with Mr. Duncan's treatment. How to manage that waste was a significant problem in Texas. We've subsequently worked through it, but it was really quite challenging. And then we've already heard a little bit about the pets and how to manage pets in Bentley. So, what have we learned? Well, with Ebola virus, we haven't seen anything that's out of the ordinary. It seems to be following the same rules that we've seen all along. We have noticed the importance of PPE, obviously, and specifically, we've seen the importance of appropriate gowning and doffing, especially the doffing to avoid contamination of our individuals. And we've seen some challenges associated with cleanup of medical waste. All right, so what's our national strategy? Well, we're all aware of that. We're screening people as they enter the country. In West Africa, we're using traditional interventions trying to separate those infected from those that are non-infected and interrupt transmission. WHO has aggressively set up, with a collaboration from CDC, exit monitoring so that prior to leaving, they're trying to exclude any sick patients, and now on entry into the United States, we're doing the same thing. And our discussion about how to quarantine is continuing on. So this is fine for a focused outbreak that comes from West Africa. If this were to become transmissible in, say, Asia or another place, how would we manage that? I think this is a challenge that hopefully we won't have to face. All right, so what do we know at this point? Well, several hospitals are well prepared to safely manage Ebola patients. Emory, Nebraska, and others have proven their worth. Clearly, we can do this if we know in advance. We run the greatest risk when a hospital doesn't know that it's an Ebola patient. They come in and they're handled just like every other patient, and oh my gosh, we've got a problem down the road. We know that self-monitoring works, that we've got a few examples now where people have self-identified, gone to seek clinical care, have been isolated and treated, and have not resulted in secondary transmission. So I think this is important as we go forward with our discussions. There's no scientific evidence so far or observations to support the risk of transmission prior to the onset of clinical disease, and I think this too is important. And we've been fortunate in that the mortality rate has been much lower here than we've seen in West Africa and other African outbreaks, which is a tribute to our care of our modern work. Out of an abundance of caution, I've come to hate this phrase because, you know what's going to follow after that, and you're just going to shake your head. So we've referred to a couple of examples. The most egregious one in my mind is incineration doesn't necessarily kill Ebola. 1,500 degrees centigrade is not sufficient. I actually, just a footnote, we had a briefing for the Texas Board of Regents, and they asked me to give an update, and I specifically said incineration kills Ebola, just so that there's no questions. The other one, I'm sure you all have your examples, but school systems closed because somebody flew on an airplane with somebody who knew somebody who had Ebola and all this. So anyway, it's lots of issues. And of course, the whole discussion that continues today about how do we manage travelers and what's the science behind this. And lots of discussion, lots of observations, and I'm not going to read all these to you, but you've all seen the headlines, I'm sure. And then the most recent nurse who said, enough already, there's no scientific basis for this, and this is continuing to be discussed, but nonetheless, it is, in my opinion, at least in personal observation, a welcome pushback on this ongoing discussion. So we've got lots of newsworthy issues here. Official comments from IDSA. IDSA does not support mandatory and voluntary quarantine. A very thoughtful editorial. This is from Arthur Kaplan at NBC News. Again, showing why this is a bad idea. So lots of discussion on this, and it's not resolved. So let me just touch on a couple of the scientific papers that I could come across that form the basis for some of our discussions. And many of the authors are here today, and I'll defer to them for the details. But I'm sure many of you saw this most recent edition of the New England Journal of Medicine. I think this was the 16th of October. This is an overview of the situation in West Africa. So let me draw your attention down here to the frequency. This is the incubation period, contact between index case and onset of disease for the next case. And you can see a nice curve here. 21 days is our cutoff. There are a few cases that appear to occur after that. You'll recall that WHO's criteria for calling a country free is 42 days, and that's exactly the reason for it. Everybody's always known that this is biological and that there are some occasional outliers. And the numbers up here, you probably can't see closely, but this is 9.4 days average for incubation period. So that's pretty good. All right, data on potential viral shedding and viral load. Let me start with a paper by Tom Kizak from the Kikwit outbreak in 1995. This is IgM titers that go up very quickly. And again, this is antigen or titers in this case on days post-onset, and the number of samples in each. So very nice data there. And then looking at antigen load viremia, if you will, and you can see again a nice curve. That was then followed by John Towner's paper from the Gulu outbreak of Ebola Sudan in 2004. And this is based on PCR, a little refinement of the data, but again, you can see the curve of starting low and going up as the disease progresses. And importantly here, the dark bars represent the fatal outcome, and the open bars are those that survived. And you can see that there's a strong correlation between viral load and the outcome of disease. The assessment of risk of Ebola virus transmission from bodily fluids, and this is Dan Bausch's work. This is the only paper I could really find. Dan can explain a little bit more, but I wanted to highlight a couple of things. Number one, this column here is PCR positive. You probably can't read it, but the bottom line is that they had 14 positive samples. And there's a whole bunch of different categories: saliva, skin, urine, vomit, sputum, breast milk, stool, and so on. The center column here is virus culture positive, and there were a total of 4 positive. Importantly, of those 4, 2 of the specimens were convalescents, one in semen and one in breast milk. We haven't talked much at all about the possibility of transmission after recovery, and I think this is something that needs a little further discussion. Dan also did a very nice study on one of the wards, sampling a whole bunch of different sites, and then attempting both virus culture and PCR. You can see a lot of negatives there, so either they were very clean, or I'll let him explain what that really means, but there was some positive results here, both in blood stain samples from doctors' gloves and all that. So, many of you have seen these papers on the persistence of the virus on various surfaces. Highlighted here is Ebola. This is work by Sagrapanti, and this was looking at the survival of virus over time, and this is in hours, and whoops, I'm sorry. This is 144 hours, and this is 2 logs of virus. So you can see that the virus survives for some length of time, perhaps longer than one might assume. This is a similar study based on storage of material. And the scale here is in days. The important point, all the results are at 4 degrees centigrade. So it appears that perhaps the virus can survive a little bit longer than one might normally assume. And this is clearly an area that additional information is needed. The 4 degrees centigrade is significant because when we were dealing with all the medical waste from Dallas, that was stored in a refrigerated truck at 4 degrees, or trailer. So we were actually preserving the material, waiting to. And then we've seen the slides already about the dog. Fortunately, Bentley is doing just fine. The only paper I could find that dealt with pets is one from the Emerging Infectious Diseases that was published in 2005. And this is from the group in Gabon. This is only antibody, but this is seroprevalence here. It's based on controls from France. And so I'm not sure exactly how to interpret this, but nonetheless, in Ebola endemic villages, there was a fairly significant number of animals positive. So what that means, I don't know, whether or not they shed virus, if it's really antibody, who knows, but it's an area for further investigation. We've talked a lot about aerosol transmission. This is the only data that you're going to see. This is from our laboratory, and we coincidentally had just completed an aerosol transmission to non-human primates, and you can see very low doses, about 100 to 200 to 500 virions, easily infected and killed non-human primates. And there's a lot of data from the military about aerosol transmissibility of Ebola virus. This, you're all, I'm sure, have seen Mike's article on this.